Okay, let's dive right into this comprehensive explainer on the syndrome of inappropriate antidiuresis, or SIAD. We are going to break down every single diagnostic criterion and etiology today, and we're doing it point by point without skipping a single detail. My absolute goal here is to make sure your concepts are crystal clear. I want this to be so thorough that you literally won't even need to open a textbook after we're done. So, let's get into it. Here's our roadmap for this session. 1. Defining SIAD. 2. Essential diagnostic criteria. 3. Supplemental diagnostic features. 4. Etiologies covering tumors and the CNS. 5. Etiologies covering pulmonary issues and drugs. And 6. Other causes of SIAD. Section 1. Defining SIAD. Now, the really crucial thing to grasp right off the bat is that SIAD is actually an umbrella term. You've probably heard of CADH a million times, right? With the H standing for hormone secretion. But SIAD is broader. It captures both excess ADH secretion and those tricky situations where the body just reacts way too strongly to normal levels of the hormone or where drugs are mimicking that effect. At its core, it fundamentally means the body is inappropriately holding on to free water. And what does that do? It dilutes the sodium in your blood, which leads straight to hyponatremia. But wait, before you even think about locking in a diagnosis of SIAD, you absolutely must heed this warning. You always have to measure serum osmolarity to rule out pseudohyponatremia. Think of pseudohyponatremia as a really frustrating lab artifact. Basically, if a patient has extremely high proteins or lipids floating around in their blood, the indirect laboratory techniques we use can make the sodium look falsely low. By actually checking the true osmolality, you confirm if the blood is genuinely dilute or if the lab is just playing tricks on you. Section 2, Essential Diagnostic Criteria. Okay, the first essential hurdle is proving that the serum is dilute while the urine is inappropriately concentrated, and you have to prove this simultaneously. You need a decreased effective serum osmolality of less than 275 milliosmoles per kilogram, and take a look at that formula on the screen. Effective osmolality subtracts the contribution of BUN. Why? Because urea freely crosses cell membranes, so it doesn't actually trap water. Now, at the exact same time, your urine osmolality must be greater than 100. If your blood is incredibly dilute, your kidney should logically be making maximally dilute urine, basically pure water, which would be less than 100. So if it's over 100, boom, the body is inappropriately holding on to water. Next up, the patient must be clinically euvolemic. This just means they show absolutely no signs of being too dry or too wet. If they have orthostatic hypotension, a fast heart rate, or really dry mucous membranes, they're volume depleted. And in that case, appropriate ADH is being released to save their volume. On the flip side, if they have edema or ascites, they have excess volume, kind of like what you'd see in heart failure or cirrhosis. For it to be SIAD, they must look clinically perfectly balanced, completely euvolemic. To round out these essential features, we need to see elevated urinary sodium, specifically greater than 40 milliequivalents per liter. Since the patient is euvolemic, the kidneys aren't actively trying to aggressively hold on to sodium. Plus, you absolutely must rule out thyroid and adrenal issues. Both hypothyroidism and adrenal insufficiency can directly cause hyponatremia all on their own. And finally, you have to confirm there's no recent diuretic use. Diuretics artificially dump sodium into the urine, which totally ruins your diagnostic picture. Section 3, Supplemental Diagnostic Features. Now, these specific supplemental lab values are fantastic because they brilliantly illustrate the dilutional effect of SIAD. Because the patient's body is hoarding so much free water, it literally dilutes other markers in the blood. So you are going to see plasma uric acid noticeably low, typically less than 4, and a BUN that is impressively low, under 10. Additionally, because the body senses that it has plenty of volume, it ramps up the fractional excretion of both sodium to greater than 1% and urea to greater than 55%. That just drives those blood levels down even further. In cases where you're still a bit uncertain, clinical fluid tests can be highly revealing. Let's say you give a patient with SIAD 2 liters of normal saline. It will actually fail to correct their hyponatremia. Why does that happen? Because the body just pees out the salt but inappropriately holds on to the water from the IV bag, which can actually worsen their sodium levels. Conversely, simple fluid restriction will successfully correct the hyponatremia simply because you are cutting off the external source of that excess water. Just a quick historical note here. While things like measuring direct ADH levels or doing a formal water load test used to be a big deal, they are rarely recommended in modern practice. A water load test basically involves giving the patient a massive volume of water and then watching them fail to excrete 80% of it over 5 hours. It's incredibly cumbersome and honestly can be dangerous if their sodium drops too much during the test. So today we generally just rely on the labs and criteria we just walked through.
Section 4. Etiologies, tumors and CNS.
All right, let's talk about what actually causes this. Malignancies are classic culprits for ectopic ADH production. Ectopic just means a tumor is secreting the hormone all by itself, totally independent of the brain. Bronchiogenic small cell carcinoma of the lung is by far the most notorious offender on this entire list. But definitely don't forget that tumors of the GI or genourinary tracts, lymphomas, and even Ewing sarcoma can also drive this exact same syndrome. Moving to the brain, the central nervous system is highly sensitive. Any irritation up there can cause the pituitary gland to just dump ADH. We see this a lot with infections like encephalitis, brain abscesses, and notably meningitis, especially in pediatric patients and in cases of TB. Head trauma is huge here too, carrying a 4.6% prevalence for triggering SIAD. Essentially, any increase in intracranial pressure, whether it's from hydrocephalus, a subdural hematoma, or a subarachnoid hemorrhage, can irritate the system right into overdrive. And it doesn't stop at infections and trauma. Structural CNS issues and neurodegenerative diseases are really well-documented etiologies. Brain tumors, cavernous sinus thrombosis, and remarkably, the postoperative state following a craniotomy are major triggers, especially if that surgery involved the pituitary or hypothalamus. We'd also see SIAD pop up in multiple sclerosis, Guillain-Barré, Shy-Drager syndrome, and even severe alcohol withdrawal known as delirium tremens. The brain-kidney connection is just incredibly delicate.
Section 5. Etiologies, pulmonary and drugs.
It is frankly fascinating how diverse pulmonary stressors can initiate SIAD. You see, it's not just lung cancer. Really common infections like bacterial and viral pneumonia, lung abscesses, tuberculosis, and fungal aspergillosis can all be triggers. Even an intense asthma exacerbation or the simple act of placing a patient in respiratory failure on mechanical positive pressure ventilation can alter their hemodynamics just enough to stimulate inappropriate antidiuresis. Now we hit a truly massive category, medications. Drugs are huge drivers of this syndrome. They do it either by causing ADH release or by making the kidneys highly sensitive to whatever ADH is already there. For instance, the diabetes drug chlorpropamide actively increases renal sensitivity to ADH. Anticonvulsants like carbamazepine, and even more commonly oxcarbazine, are frequent offenders. We also see this all the time in the clinic with psychiatric drugs, particularly SSRIs and tricyclic antidepressants. And, of course, don't forget the diuretic HCTZ, which is famous for inducing severe hyponatremia. Continuing with our drug list, chemotherapeutics like vincristine, routine antipsychotics, and even common over-the-counter NSAIDs can forcefully disrupt water balance. A very classic board exam and real-world trigger is the recreational substance MDMA, or ecstasy. It causes a massive ADH release and subsequent severe hyponatremia. Finally, direct analogs like DDAVP obviously cause this, but so does oxytocin. Oxytocin actually shares structural similarities with ADH, which causes direct cross-reactivity at the kidney receptors. Section 6. Other causes of SIAD. As we mentioned earlier during the diagnostic criteria, if you haven't found the cause yet, you absolutely must evaluate the endocrine system. You have to explicitly test for and rule out adrenal insufficiency and hypothyroidism. Both of these states reduce cardiac output or alter systemic hemodynamics in a way that physiologically stimulates ADH, basically mimicking the primary syndrome to a T. And hey, never underestimate the physiological impact of the body just being in general distress. Severe pain, profound nausea, systemic stress, or acute hypotension natively stimulate ADH release. It's a survival mechanism to retain water. This is exactly why the general postoperative state is so fraught with hyponatremia. The pain and nausea of surgery cause massive ADH spikes. Oh, and rounding out the list, acute intermittent porphyria is a rare but classic metabolic cause you should definitely keep in your back pocket. So having meticulously unpacked every single point of CIAD criteria and causation, from those rigid osmolality numbers to the massive list of offending drugs and tumors, the real question is, how will you apply this structured pathway to solve the puzzle of your very next hyponatremic patient? Will you remember to check the uric acid? Will you review their medication list for SSRIs? I really hope this detailed explainer has cleared up all those concepts for you so you don't even need to look at a textbook. Keep exploring, stay curious, and I'll catch you in the next explainer.